Hello, today we'll continue our series of lectures on behavioral science. The topic we're going to cover today is sexuality, and I suppose that in as much as sexuality is always fun and interesting, we'll divide this topic in two lectures. So today we'll cover lecture one, and the next lecture we'll cover the second part of sexuality. Sexuality, very much as aggression, is a very important topic in behavioral science. Because, what's not related to sex, right? Everything is related to sex. From a medical point of view, sexuality is very important because there are some psychiatric conditions that have a lot to do with sex. And there are also some sexual dysfunctions that we'll cover. Although we'll not cover sexual dysfunctions today, we'll cover sexual dysfunctions in the next lecture. So keep in mind that all these topics will appear in the USMLE. So at the end of this lecture, we'll do some review questions with items that resemble the ones that appear in USMLE. Now, sexuality is not just about the proper act of having sex with someone else, but it also, from a medical point of view, has to do with biological differences between the sexes and also psychological differences between genders. So we'll cover some of those topics today. So let's begin with considering, from a biological point of view, how do sexes come about? What is the process by which boys and girls become differentiated from the moment they're born? And this actually happens, even before they're born. So there is a prenatal physical sexual development. Now, as probably you learned in the genetics 101 or even in high school genetics, the genetic difference between boys and girls is the XX chromosome and the XY chromosome. So in boys, the Y chromosome is present, and this Y chromosome has the testing determining factor gene. According to which of these alleles you have, which types of chromosome, whether you have XX. If you're XX, you turn out to be a girl. If you have XY, you turn out to be a boy. Now, there are some cases where you may genetically be a boy or a girl, depending on the chromosomes that you have, but the prenatal physical sexual development may have some alterations, and that may affect the way you turn out to be. And this mostly has to do with hormones. So you may be genetically of one sex, but if you have a different endocrine development during your prenatal or phase of development, then that may alter your sexual development. So genetically you may turn out to be a boy, but when you're born, your genitalia may resemble and your behavior may resemble more that of a girl. So there are some important conditions that we should know. It's important to understand that it's not only genes, and hormones also play a role. And androgen hormones direct the differentiation of male internal and external genitalia. So both genes and hormones will ultimately decide what your genitalia will be. So there are some cases of intersexuality. And intersexuality, as I was saying, is when you're born, you're assigned either one sex. You're either a boy or a girl. And in most cases, in the overwhelming majority of cases of when people are born, they're easily assigned to either sex. But there is a very small percentage of people that are born that it's not so easy to assign them to either one sex. And these people are called intersexuals. And intersexuality is the condition where the sex that the person belongs to is ambiguous. Now you may say, well, it's easy to determine just by taking a look at the genes, but no, it's not that easy because of hormonal factors. Genitalia may turn out to be different. So there are many intersexual conditions, and we'll take a look at some of them. For instance, there could be an absence of androgen hormones. So in this case, even if you have an XY chromosome and genetically you're supposed to be a boy, if there is an absence of androgen hormones, remember that those hormones have the function of let's say determining how your genitalia will be. So in this condition of absence of androgen hormones, it may be that you have an XY chromosome, but that nevertheless your genitalia will still be female. So, that's one condition. Another condition is androgen insensitivity syndrome. So in this case, the testes secrete androgen, but the cells do not respond to androgen, and as a result, you have a female genotype. So in this case, you have both XY chromosomes, so genetically you're supposed to be a boy, and you do have, let's say, hormones that are more frequently found in boys, right? Androgen. However, although the fact that your body secretes androgen, the cells do not respond well to the androgen, and as a result, you develop a female phenotype. So genetically you may be a boy, but in the phenotype you resemble more a female. Another condition, excessive adrenal androgen, and this is when you may be a girl, you may have an XX chromosome, but your body may secrete too much androgen hormones, and in that case the result will be masculinized female genitalia. There are some other intersexuality conditions that don't really have so much to do with hormones, but with other causes. So let's take a look at a few of them. There's first of all penile agenesis, and this is boys that are born without penises. There's also vagina agenesis, and well, this is the other way around. These are girls that are born without vaginas. There is Klinefelter's syndrome, and this is these are boys that have, of course, XY chromosome, but they may have an additional X chromosome. So in this case, you would have XXY chromosome. Instead of having the traditional 46 chromosomes that we all do have, you would have 47. And of course, this is part of the chromosomal abnormalities. Down syndrome is probably the most famous chromosomal abnormality, although because Down syndrome is not concerned with the XX syndrome or the XX chromosome or the XY chromosome. Down syndrome is not related to intersexuality. But chromosomal abnormalities are, they are some medical conditions that some of them, not all of them, but some of them have some incidence on mental disability or on intellectual disability or mental retardation, as it used to be known. So some of these intersexual conditions may also have as symptoms some intellectual disabilities, although not all of them. In Klinefelter syndrome, usually the symptoms here are not so pronounced, and the diagnosis for Klinefelter syndrome may usually be a little bit delayed because patients don't exhibit the symptoms until much later in their development. But eventually they may turn out to be diagnosed as intersexual. Remember, intersexuality is not just one condition, it's a series of conditions that result either from chromosomal abnormalities or from some problems in the hormonal development, especially during the prenatal sexual development phase. Another chromosomal abnormality that also influences or that also results in another intersexual condition is Turner syndrome. And then this is for girls. These are girls that are born with only one chromosome. So in Klinefelter syndrome, people have 47 chromosomes, and it's males with an additional X chromosome. In Turner syndrome, patients have 45 chromosomes because they're lacking one chromosome. They only have one X chromosome, so they turn out to be girls, but they also have some other symptoms that they may eventually result in. They're not in the case of Turner syndrome. They don't have they usually have normal intelligence, but they have other debilitating symptoms in some physiological features. So what can doctors do in the case of intersexuality? What's the treatment? Well, usually they work with a sex assignment. So, I mean, depending on, regardless of the genetic makeup, they will assign sex on the basis of the phenotype. I mean, let's say someone is genetically a boy because they have XY syndrome, but because of some hormonal problem, they may resemble genitalia that are more similar to girls. Well, in that case, usually what the doctor's procedure here will be to assign them to a sex that is that resembles more their genitalia and other outward physical features that they may have. Most physicians do not recommend rushing surgery in order to modify genitalia. What physicians usually recommend is, waiting for a little bit longer until a proper decision can be made, screening the sexual development of the person. So most intersexual babies do not need immediate surgeries, so that's why most physicians do not recommend rushing this. There are some sad stories regarding intersexuality. There was a famous case of David Peter Reimers. This was a boy who, as soon as he was born, he underwent circumcision, but the circumcision turned out to be quite tragic because during the procedure, his penis was amputated. So there was a famous doctor, Dr. John Money, who argued that if this boy's penis was amputated, there would be no problem, because if he was raised as a girl and he was given some additional hormones, he could easily change from one sex to the other. So Dr. John Money, he believed that he could change sex from infancy solely with genital modification and gender socialization. But this didn't turn out to be the case. David Peter Reimer, who was the patient, although he was eventually raised as a girl because he had no penis, he always felt as a boy, and he was severely disturbed by this, and he ultimately committed suicide. And Dr. John Money was criticized significantly for having pushed too much his idea that with just raising a boy as a girl, he would eventually feel as a girl, and that there would be no problem with that. And no, it seems like biology is deeper than that, and that if you have if you are, first of all, genetically a boy, and also you have hormonal development that make you feel more like a boy, then no matter, regardless of whether or not your genitals are changed, that's because of some surgical procedure, and that's not gonna change things so easily. So even during prenatal psychosexual development, there are some differences between boys and girls. So gender difference in some brain areas result from different exposure to gonadal hormones. So androgen insensitivity syndrome usually results in a female gender identity, female gender role, and sexual preference for men. So the way hormones work out before you're born ultimately have some significant influence on how you feel to be. And maybe this has to do with gender dysphoria and the sense of gender identity. Gender dysphoria is a mental disorder that we'll get shortly to. Gender identity is the sense of self as male or female that is developed at about 3 years old. So if you remember from our lecture on developmental psychology, we studied how at around 3 years old, boys and girls begin to understand, well, who's a boy and who's a girl, and they begin to feel identified with either gender. So this is the sense of gender identity. Now, gender dysphoria is, and this is a mental disorder that is categorized in the DSM-5. It used to be called gender identity disorder. This is when the patient feels that he's not living in the body that he feels most comfortable with in terms of gender. So someone may have been assigned as a man in terms of gender because of their genitalia and so on, but they may still feel like a woman. So this is called gender dysphoria because they're not happy with the gender they have been assigned, and of course this causes some distress. It is estimated that between 0.5 and 1% of the world population suffer from gender dysphoria. So that's the epidemiology of gender dysphoria. In adulthood, this varies because someone may have a gender identity or gender dysphoria during their childhood, but they may eventually overcome it. And the DSM-5 specifies different criteria for children and for adults, and we'll get to that shortly. In adulthood, it's much more common for biological men to feel like women than for biological women to feel like men. So in adulthood, there is a 3-to-1 ratio male-female gender dysphoria. As you probably know, this has been in the news over the last few years because of some very high-profile cases, such as this one that we have here, Bruce Jenner. I was surprised. I didn't really know his story all that well, but you know, preparing for this lecture, I was surprised to find out that he was quite a muscular type of guy, and that he was an athlete, and he eventually made this transition towards being a woman. There have been some people that claim that maybe media exposure to this topic is increasing the disorder itself. Now, most psychiatrists will reject this hypothesis, but I think some consideration should be given to it because in other mental disorders, such as dissociative identity disorder, or what's called multiple personality disorder, that used to be an extremely rare disorder. But the media began to portray movies and series and books about people who developed multiple personalities. And as soon as the media began to develop, to portray those cases, all of a sudden it apparently became something much more common in terms of epidemiology. Some people are claiming that this could also be the case with gender dysphoria. I mean, so much attention is given to this in media that maybe people who would never develop this disorder, media exposure may eventually increase the epidemiological status of this disorder. Psychiatrists are very skeptical of this hypothesis, but you know, I'm just mentioning it here because it has been open to debate. So let's go to what the DSM-5 has to say about gender dysphoria. Let's consider first of all gender dysphoria in children. So the criteria of the DSM-5 is first of all for children. In order to diagnose this, it's first of all an incongruence between one's assigned gender and experience for at least 6 months with at least 6 of these symptoms. First of all, a strong desire to be the other gender, a desire for cross-dressing, a desire for cross-gender roles in play. So if you're a boy and you like to play with Barbie dolls, or if you're a girl and you like to play, I don't know, with trucks or machine guns, well, that could be symptom number 3. I'm sorry, symptom number 4. Also, preference for playmates of the other gender. Remember that it is during this phase of development, it is quite normal for children to prefer to play with other children of their own gender. If they have a strong preference for playmates of the other gender, then this may be one of the symptoms that is taken into account for criteria for diagnosis. Rejection of gender's toys. This had to do with the previous symptoms. Dislike of one's sexual anatomy. Desire for others' genders and sexual anatomy. So, you know, this, if you're a boy, you dislike your penis and you would like to have a vagina. And if you're a girl, well, the other way around. Now, in order, as in almost every other mental disorder, in order for this to be diagnosed, this has to cause distress or impairment. I mean, if the person doesn't feel that he's the gender that he has been assigned with, but that doesn't cause distress or impairment, well, then that's not considered a disorder, because in order for it to be, in order for some behavior, some mental pattern to be considered a psychiatric disease, a mental disorder, it has to cause distress. That's one of the main differences between pathological behavior and normal behavior. This can also be diagnosed for adults. So there's also gender dysphoria in adults. This is the DSM-5 criteria for gender dysphoria in adults. Well, first of all, an incongruence between the assigned gender and the experienced gender for at least 6 months with 2 or more of these symptoms. In the case of children, it's 6. In the case of adults, it's only 2 or more. And then again, we have an incongruence between one's experienced sex and one's sexual characteristics. Desire to be rid of one's sex characteristics, a desire for the other sex characteristics. So if you're a man and you have this disorder, you say, oh, I wish I didn't have penis, and you know that I wish I was given a vagina. Desire to be of the other gender, desire to be treated as the other gender, and conviction of having feelings of the other gender. So if you have 2 or more of those symptoms, then you meet criterion A. And you also need to meet criterion B, and again, that is a distress or impairment. So we're not really sure what are the causes of gender dysphoria. Bear in mind that this is something that psychiatry is only starting to deal with, and you know, the high-profile cases in the media is giving it more attention, but the understanding of this disorder is still in its infancy. And you know, there are some people. Gender dysphoria is becoming quite controversial because of the LGBT movement and so on. And there are some people who are trying to depathologize gender dysphoria, to say that this is not really a disorder, it's just a way of living, and so on. On the other hand, there are some people, also from the LGBT community, who are saying, well, no, look, but people are suffering, so because when they don't feel part of the assigned gender, so they should be given help. And there are yet some other people who say that there shouldn't be, and these are the more radical feminists and the more radical people that belong to the queer community or the LGBT community. And these people say that that division between genders is arbitrary, and that gender and sex is it's a social construction, and that we shouldn't really have divisions between men and women. And to a certain extent, all the toilet controversies in the United States about whether or not there should be only 2 types of toilets, but whether there should also be additional toilets for additional genders. Well, all of that forms part of this debate. So this is only beginning to come up in public discussion, and psychiatry is only beginning to understand some of the causes and what are the possible treatments for these conditions. So one of the possible causes for gender dysphoria could be altered prenatal brain exposure to sex hormones. So if you're genetically a boy, but during your prenatal behavior, your prenatal development, your brain was exposed to sex hormones that correspond actually to the other sex, then they may eventually cause, as a child or as an adult, gender dysphoria. The treatment is tricky again, because there is a lot of debate on this. The first line of treatment is usually supportive psychotherapy. So if someone has gender dysphoria, well, the recommended option here is maybe going to the psychiatrist or the psychologist, you know, to figure out the problems that are going through, and maybe using some psychotherapeutical approach, either cognitive behavioral therapy or maybe group therapy, in order to overcome some of the distress that it comes as a result of gender dysphoria. Now, if that is not enough, well, some physicians have recommended hormone therapy. So, I mean, if you're a man and you feel more like a woman, then maybe you could be provided with hormones that are more proper of the female gender, and that way you may eventually make a transition. And if still that's not enough, then you know, a full transition could be made with sex reassignment surgery, and there have been many of these performed. Okay, so apart from that, let's talk also about gender roles in society. Well, a gender role is the expression of gender in society, and that is how society expects you to behave. That's your gender, which is different from sex. I mean, sex is your actual biological characteristics. Gender role is the way society expects you to behave. So there is a societal pressure to conform to gender stereotypes. And of course, unlike sex, which is universal, you know the difference between boys and girls. I mean, it is universally accepted that boys have penises and girls have vaginas. When it comes to gender, this varies cross-culturally. In some cultures, men are expected to do some things. In other cultures, women are expected to do some other things. Now, even though there are cultural variations in gender expectations, let's not make too much of it because there are some universals. I mean, universally, men are expected to participate more in army professions. I mean, universally, soldiers have been men, and women have done other types of tasks in society. One may say, well, but look, there's the Amazons. Well, yeah, but the Amazons are probably myths. And even if there were some remote society where the warriors were not males but females, that wouldn't be really statistically significant. So there are some universal tendencies that some roles are performed by men and some other roles are performed by women. Now, of course, this is changing because even in the case of soldiers, there are now many female soldiers in the American forces, and especially, for instance, in the Israeli forces. In Israel, women have a very strong participation in the armed forces. And just because universally there have been some gender roles assigned to one gender and not to the other, that doesn't mean that that cannot change. This is what in philosophy would be called a naturalistic fallacy. So just because something has always been the case, that doesn't imply that it has to continue being that way. But it is nevertheless true that although there are some cultural variations regarding gender roles, for instance, I usually use this humorous example. I mean, in Western society, there is the expectation that men wear pants and women wear skirts. But if you go to Scotland, well, women, or even in Fiji, men over there, they're culturally expected to wear, in the case of Scotland, the kilt, or in the case of Fiji, skirts that resemble the ones that females wear. So that's something that's socially constructed. Society imposes that on the gender, and it doesn't necessarily have to be universal. But again, I want to emphasize that there are some other gender roles that are universal, and if they are universal, they may have a biological basis, although not necessarily. Just because some trait is universally found across culture, we shouldn't jump to the conclusion that it has a biological basis. But nevertheless, there are some gender roles that are indeed universal. Let's talk about sexual orientation. This is always an interesting topic, of course. Sexual orientation, we can define it as the preference for people of the same sex, the opposite sex, or both. So you can be homosexual, heterosexual, or bisexual. And as we talked about in a previous lecture, especially when we talked about developmental psychology, when people begin to experience their sexual preferences, there may be a time of sexual experiencing with different types of orientation. And some psychologists have proposed rather a continuum or a spectrum of between homosexuality and heterosexuality. I mean, some people may not be entirely either homosexual or heterosexual, but you know, they may be placed on a continuum. So sexual orientation is not the same as gender identity or gender role. I mean, you may be a man. Biologically, you may very much feel like a man. You may perform masculine roles in society, and nevertheless, you may still prefer other men when it comes to sex. So, being gay, if you're a man, it's not about feeling like a woman. And this is a common media myth that all gay men are somehow feminine, and that they resemble women. It is true that from a biological point of view, some biological characteristics of homosexual men resemble a little bit some of the biological characteristics of heterosexual women. but we shouldn't make too much of it because, as I'm saying, gender identity is not the same as sexual orientation. Just because you have a sexual preference for men, if you're a man, that doesn't mean that you feel as a woman. It's very interesting to point out that in the DSM, we're currently in the 5th edition. But up until the 3rd edition, homosexuality was considered a pathology. Not anymore. So you will not find homosexuality listed as a mental disorder in the DSM, but in the past it used to be included. And the case that homosexuality is included was formerly included as a disorder. That has been an argument for many people who oppose the discipline of psychiatry, because some people say that psychiatry is not a real branch of medicine, but rather it is a political tool that is used by some groups to pathologize those behaviors that some people just don't like. And the case of homosexuality is one of them. Now, I think that anti-psychiatrists, in the case of homosexuality, they may have a point, and in fact, they do have a point. But I think they would overgeneralize to say that all of psychiatry is politically or morally motivated, because that's not the case. I mean, I think there is a genuine objective difference between pathological behavior and normal behavior. Now, although homosexuality is no longer included in the DSM, there is some discussion about whether or not ego-dystonic homosexuality should be included. And ego-dystonic homosexuality is a sexual orientation or attraction that is at odds with one's idealized self-image, causing anxiety or distress and a desire to change one's orientation or become more comfortable with one's sexual orientation. So ego-dystonic homosexuals would be those gays and lesbians who are not happy with being gays and lesbians. They are they don't feel satisfied with their own sexual orientation, and that causes distress. Now, the DSM-5 does not include ego-dystonic homosexuality as a disorder, but there's some debate about this. I mean, there are some people who say that, well, yeah, sure, homosexuality should not be considered a mental disorder because it doesn't cause distress, it doesn't cause problems to other people, it's just a way of living. However, if homosexuality does cause distress, in the sense that people are not happy with their sexual orientation, then maybe it should be included as a form of mental disorders. And in that case, it wouldn't just be homosexuality as a disorder, but rather ego-dystonic homosexuality. Now, one of the great questions in psychology is why do people turn out to be gay? What is the etiology of homosexuality? And there's no definite answer to this. We can only consider some tentative answers. First of all, there may be alterations in the levels of prenatal sex hormones. So increased androgens in females and decreased androgens in males may eventually influence someone's sexual orientation. And this is why I was saying that biologically it could be the case that homosexual men may resemble, in some aspects, heterosexual women, and homosexual women may resemble, in some biological aspects, heterosexual men. But again, let's not make too much of this. It has also been found that some anatomic changes in the hypothalamic nuclei during the prenatal phase of sexual development may occur due to prenatal hormone exposure, and those anatomic changes in that area of the brain may actually lead to homosexuality. It has been found that homosexuals and heterosexuals do have some differences in brain anatomy and brain physiology. Lesbians and heterosexual men have a more asymmetrical brain. The right side of the brain tends to be a little bit bigger in lesbians and heterosexual men, whereas homosexual men and heterosexual women have a more symmetrical brain. Now, how does that exactly cause homosexuality? Well, we don't know, but we do know that there is a correlation between these brain features and sexual orientation. And apart from the brain, there are other biological correlations that are quite interesting, and they're not properly predictors of homosexuality, but they have a strong correlation. There's first of all the digit ratio. Higher prenatal exposure to testosterone may decrease index ring ratio. So homosexual men tend to have a higher ratio. So in the case of homosexual men, the index finger may be longer than the ring finger. And you can test it on yourself. Now, of course, if your index finger is longer and you're a man, that doesn't necessarily imply that you're homosexual. But as I'm saying, there has been some correlations done, and the correlations turn out to be rather strong. There's also a high correlation between heterosexuality and being right-handed. So homosexuality and left-handedness are also strongly correlated. But again, I must emphasize that these are only working hypotheses, and so far we're not so sure why people turn out to be gay, and they're just correlations. There's always a possibility that sexual orientation may have a genetic origin. So apparently some markers on chromosome X have been found with homosexual populations, and that's a working hypothesis that maybe some of those markers in chromosome X may actually determine someone's sexual orientation. Homosexuality has some rather high heritability. Remember that heritability is it's a measure of deciding how much of variation regarding one trait is due to genetics. So when twins have been compared, they find out that the heritability is of 0.45, and when it comes to sexual orientation. Now, a great evolutionary puzzle regarding homosexuality is that, okay, if there are gay genes, I mean, if homosexuality has a genetic basis, how can those genes be passed to the next generation? And let's say that you have a gene for being gay. Well, if you're gay, you're not going to have children. And if you're not going to have children, then how is it possible that those genes that you have for being gay will persist in the gene pool? I mean, how can gay genes be passed? And there are various theories regarding this. It could be, and some evolutionary psychologists have proposed this, it could be that a low dose of gay genes may not be enough to make someone gay, but may make you more sexually attractive to women. So that is how gay genes may be passed, and when someone has a really big dose of those genes, well, you may be sexually attractive, but eventually you may turn out to be gay. So you will not be able to pass those genes yourself, but other people with lower doses may actually be at a greater advantage for passing those genes. I mean, that's one mechanism for passing gay genes to the next generation. Another very famous hypothesis in evolutionary psychology regarding genes and gays and homosexuality is the gay uncle theory. And according to this theory, it could be that those people that have genes for being gay may also, those very same genes may also be responsible for increasing altruistic behavior towards other people that are related to them. Now remember, this goes back to Hamilton's theory. Well, in this case, according to the hypothesis, if you have genes for being gay, those very same genes could also make you, metaphorically speaking, a better uncle. So you could take good care of your nephews and nieces. And if that is the case, then inasmuch as those nephews and nieces carry your same genes, well, by helping them out, you're also helping them to spread their own genes, and that is how the gay gene can be also spread. So maybe you will not have children of your own, but if you take care of other children that are genetically close to you and you are gay, then that is how your gay genes may be passed to the next generation. And more recently, there is a famous biologist. His name is Gregory Cochrane, and he has put forth the hypothesis that maybe homosexuality doesn't really have anything to do with genetics, but it may actually be a virus. Now, this has caused some controversy because gay people have been offended, but I think it's a working hypothesis, and the jury's still out about whether or not maybe the homosexuality may actually be a virus. Now, of course, viruses have very negative connotations, but this doesn't necessarily have to be the case. I mean, here Cochrane is not implying that being gay is a pathological condition. He's just claiming that the etiology may actually be viral. Birth order may also have to do something with male homosexuality. So it has been found that the more older brothers a man has from the same mother, the greater the probability is that he will be homosexual. And why does this happen? Well, it has to do with what has been called the maternal immunization hypothesis. Now, according to this hypothesis, pregnant women develop an immune reaction to an antigen that turns the male fetus heterosexual. So the more pregnancies a mother has, the stronger the immune reaction from the mother towards the fetus. So in that case, the younger brother, in as much as the mother has had more pregnancies, that has given the mother the chance to develop a stronger immune reaction against that antigen. So that antigen in the younger brother is weakened, and in that sense, it may not fulfill its function properly of turning the male fetus heterosexual. And there is a statistical correspondence that there is a much greater chance of a man turning out to be gay if he has many older brothers from the same woman. But again, this is only a hypothesis as the previous ones, so we shouldn't make too much of it. Let's address some common myths about homosexuality that are usually exploited in the media. First of all, there is the idea that homosexuality and pedophilia are related, and that's absolutely not true. The Catholic Church has unfortunately given voice to this argument, but it has been refuted. There is also the common myth that people turn out to be gay because they have been sexually abused. That's also not true. It is nevertheless true that as we studied in the last lecture, that sexual abuse may be an etiological factor in the case of pedophilia. If you were sexually abused as a child, that increases the risk that you may become yourself a sexual abuser. But that doesn't apply to homosexuality. It's also a myth that if you are raised by someone, if you're raised by gay parents, or if you don't have a role model or a parent of the same sex, then you may turn out to be gay. So if you're raised by your mother and your sisters, but there are no men in the household, then if you're a man, you will turn out to be gay. That's a myth. Remember that homosexuality either has a strong genetic component or a hormonal component. But being raised by people of the other gender, that doesn't have any influence whatsoever. It's also false that homosexuals have a shorter life expectancy, and that they have a poorer mental health, and that they have increased substance abuse risk. It seems to be false that it's a choice. I mean, you're born with this, either due to genes or hormones or whatever else. So people just can decide to stop being gay and turn into heterosexual. And that is why conversion therapy is really a loss of time. I mean, every time conversion therapy has been tried, especially by evangelical fundamentalist groups, this has met utter failure. And there have been some very high-profile cases of evangelicals that have proudly claimed to have been homosexuals in the past, and they now claim to be cured, quote-unquote cured from homosexuality, and after a while, well, they turn out to be caught with their pants down with other men. So this speaks a lot about the hypocrisy going on in conversion therapy and in fundamentalist circles. Now, there are some rather uncomfortable facts regarding homosexuality. It is true that gay men have a higher incidence of or prevalence of promiscuity. So it is true that gay men tend to be much more promiscuous than heterosexual men, than heterosexual women, or than even homosexual women, than lesbians. So this is not just a media stereotype. I mean, this is supported by facts. And although there's some more controversy regarding this, it is still a fact that domestic violence rates in homosexual relations tend to be slightly higher than in heterosexual relations. Although, again, the data is not conclusive. Okay, so let's talk briefly about biology and sexuality in adults. It's important to know that menopause does not reduce sex drive in women. So women after 45 or 50, they are still as sexual as any other age. Testosterone does influence libido, which is sexual energy, and is continuously produced throughout the lifetime. So, you know, elderly people can perfectly have sex just because there are some changes in the development. That doesn't mean that they're not able to have sex and that they have decreased libido. They may have problems, erection problems, and in the next lecture we'll cover some sexual dysfunctions, but this is different from the decreased libido. Psychological and physical stress may decrease testosterone levels, so this is something to watch for. Too much stress may actually make you feel with less sexual energy. And progesterone, which is found in oral anticonceptives for women, may decrease libido in women. So this is something that you doctors should be aware of. And let's talk about how sexuality actually happens and what are the biological correspondences to the sexual act itself. There is a very famous model of the sexual response cycle that was devised by Master and Johnson. These are two famous people who studied how humans interact sexually. And there are basically 4 stages in the sexual response cycle. There's first of all the excitement stage. So this is, you know, warming up, so to speak. And during the excitement stage, there is a penile erection in men, and in women there is a clitoral erection, labial swelling, and vaginal lubrication in women. So this is when both men and women begin to get excited. This is the excitement stage. There is also increased pulse, the blood pressure goes higher, and there is a faster respiration, nipple erection, so the nipples go up a little bit. This is during the excitement stage. I mean, this is when arousal is beginning. After that, there is what's called the plateau stage. Now, it's called the plateau stage because, as you will later see on the graph that I will show you shortly, the line of arousal in the first stages goes immediately up, but then after a while it becomes flat. And that's why it's called the plateau stage. And now during the plateau stage, in the case of men, there's an increased size and upward movement of the testes. There is a secretion of a few drops of sperm containing fluid. So during this plateau stage, after examining, is when penetration actually happens. There's some people who believe that a contraceptive method is a coitus interruptus, and that is to say, you know, to have penetration, but just prior to the moment of orgasm, to withdraw the penis from the vagina. And they think that that's effective, but it's very risky because during the phase of penetration, during the plateau stage, there may still be a secretion of a few drops of sperm containing fluid. So if you really want to have contraception, you need to look for other methods. In the case of women, during the plateau stage, there is a contraction of the outer 1/3 of the vagina. So the vagina contracts a little bit. And there is a further increase in pulse, blood pressure, and respiration, although that increase is not as steep as in the excitement phase. During this stage, there is a flushing of the chest and face. So yes, people do turn out to be red, or their skin turns reddish when they're having sex, especially during the Plato stage. So after that, there is the orgasm stage. So this is when the forcible expulsion of seminal fluid happens. In the case of women, there is a contraction of the uterus and the vagina, and there is even more increase in pulse, blood pressure, and respiration. So what happens after orgasm? Well, there is the resolution stage. Now in here, I mean, so far in men and women, the stages have been relatively similar. But in the case of the resolution stage, men and women differ. For men, there is a refractory or resting period, and the length varies by age and physical condition. But in the case of healthy young men, it's about 15 or 20 minutes. Now, this is very important here to know that in the case of women, there is no refractory period, or it's very little. So a woman can have an orgasm, and she may immediately be ready for the next orgasm. In the case of men, once men have an orgasm, they cannot have an orgasm immediately. They need the refractory period. So after orgasm, there is muscle relaxation, and the return of the sexual and cardiovascular systems to the pre-stimulated state over 10 or 15 minutes. That's the resolution stage. Here in this graph, you can see the differences between males and females. Males are blue, females are red. So in the case of men, you can see how the line goes up during excitement. It's very steep. In the case of Plato, during the Plato phase, the arousal keeps going up, and high blood pressure and respiration and so on keeps on going. But it's a little bit more flattened because it's during the phase of penetration. But then it steeps itself again when it reaches orgasm, and after orgasm, it decreases abruptly, and this is the refractory period. Now, in the case of females, which is the red line, she may be excited, so she may have a steep increase in arousal, and during the Plato stage, she may have a very flat line, and that's when women have sex and don't reach orgasm. And we'll get to in the next lecture about some conditions of women that are not able to reach orgasm. But she may also, after the Plato stage, she may reach orgasm. Now, there may be a very short refractory period for women, so you see the line decreasing down, but she's ready again to have a new orgasm. And some sexologists and sexual therapists recommend that if a woman reaches orgasm and the man reaches orgasm, well, after that she may masturbate herself, even in front of the man. That's perfectly normal to do, so that she may reach further more orgasms, because she's ready for more. Unlike the man, after the man reaches orgasm, then there is a refractory period, and the blue line comes all the way down. In the case of women, she may reach the orgasm, but she may continue. So the refractory period is much shorter. Or actually, there may even be no refractory period at all for the case of women. That wraps up our lecture. So let's do one USMLE question before we finish today. So let's consider this. A 29-year-old woman says that she has always felt as if she was a man in the body of a woman. Physical and pelvic examinations are normal, and she is sexually attracted to heterosexual women and wants to wear men's clothes. She wants to take male hormones, and she wants to undergo a mastectomy and surgical sex reversal so that she can live as a man. So the final diagnosis for this patient is most likely to be A, androgenital syndrome, B, androgen insensitive syndrome, C, gender dysphoria, D, transvestic fetishism, or E, normal. Well, she's neither A nor B, because those are intersexual conditions, and that's not the case here. I mean, biologically, she is a woman. Both genetically and biologically, and genetically and phenotypically. The transvestic fetishism, we'll get to fetishism in the next lecture when we cover some of the paraphilias, But no, this is not transvestic fetishism, because transvestic fetishism is when people are aroused sexually by being dressed with clothes of the other gender. But this is not the case. I mean, this is not just about having sex, being dressed as a man. This is wanting to live as a man. Is she normal? No, she's not normal, because I mean, if you are biologically a woman, then you're expected to feel as a woman. So if you are biologically a woman but you feel as a man, then the correct answer here would be C, gender dysphoria. Chromosome has the testing determining factor gene. According to which of these alleles you have, which types of chromosome, whether you have XX, if you're XX, you turn out to be a girl. If you have XY, you turn out to be a boy. Now, there are some cases where you may genetically be a boy or a girl, depending on the chromosomes that you have, but prenatal physical sexual development may have some alterations, and that may affect the way you turn out to be. And this mostly has to do with hormones. So you may be genetically of one sex, but if you have a different endocrine development during your prenatal or phase of development, then that may alter your sexual development. So genetically you may turn out to be a boy, but when you're born, your genitalia and your behavior may resemble more that of a girl. So there are some important conditions that we should know. So there are many intersexual conditions, and we'll take a look at some of them. For instance, there could be an absence of androgen hormones. So in this case, even if you have an XY chromosome and genetically you're supposed to be a boy, if there is an absence of androgen hormones, remember that those hormones have the function of let's say determining how your genitalia will be. So in this condition of absence of androgen hormones, it may be that you have an XY chromosome, but that nevertheless your genitalia will still be female. So, that's one condition. Another condition is androgen insensitivity syndrome. So in this case, the testes secrete androgen, but the cells do not respond to androgen, and as a result, you have a female genotype. So in this case, you have both XY chromosomes, so genetically you're supposed to be a boy, and you do have, let's say, hormones that are more frequently found in boys, with items that resemble the ones that appear in USMLE. Now, sexuality is not just about, the proper act of having sex with someone else, but it also, from a medical point of view, has to do with biological differences between the sexes, and also psychological differences between genders. So we'll cover some of those topics today. So let's begin with considering, from a biological point of view, how do sexes come about? I mean, what is the process by which boys and girls become differentiated from the moment they're birth? From the moment they're born. And this actually happens, well, even before they're born. So there is a prenatal physical sexual development. Now, as probably you learned in genetics 101 or even in high school genetics, the genetic difference between boys and girls is the XX chromosome and the XY chromosome. So in boys, the Y chromosome is present, and this Y chromosome, it's important to understand that it's not only genes, and hormones also play a role, and androgen hormones direct the differentiation of male internal and external genitalia. So both genes and hormones will ultimately decide what your genitalia will be. So there are some cases of intersexuality. And intersexuality, well, as I was saying, is, I mean, when you're born, you're assigned either one sex. You're either a boy or a girl. And in most cases, in the overwhelming majority of cases of when people are born, they're easily assigned to either sex. But there is a very small percentage of people that are born that it's not so easy to assign them to either one sex. And these people are called intersexuals. And intersexuality is the condition where the sex that the person belongs to is ambiguous. Now you may say, well, it's easy to determine just by taking a look at the genes, but no, it's not that easy because of hormonal factors, genitalia may turn out to be different. Hello, today we'll continue our series of lectures on behavioral science. The topic we're going to cover today is sexuality, and I suppose that inasmuch as sexuality is always fun and interesting, we'll divide this topic in 2 lectures. So today we'll cover lecture 1, and the next lecture we'll cover the second part of sexuality. Sexuality, very much as aggression, is a very important topic in behavioral science. Well, because, I mean, what's not related to sex, right? Everything is related to sex. From a medical point of view, sexuality is very important because there are some psychiatric conditions that have a lot to do with sex, and there are also some sexual dysfunctions that we'll cover. Although we'll not cover sexual dysfunctions today, we'll cover sexual dysfunctions in the next lecture. So keep in mind that all these topics will appear in the USMLE. So at the end of this lecture, we'll do some review questions.